Okay.
Okay.
Okay, Dr. Adam, can you hear me?
Yes, I can hear everyone.
Okay, this is time. We can start our webinar now. Medical. Welcome to attendance the global webinar of Masonic Dangling College. Masonic Dangling College is a free online platform for purpose of learning the cutting edge and entitled point of care ultrasound application with a global professional medical participant. Today we have honor to have Dr. Adham AboulFotouh, our webinar speaker, and Dr. Abdallah El-Sayed Allam, our webinar moderator. Today our webinar will be divided into two major sections. The first section is a speech by Dr. Adham. Let's take about 50 minutes. And second section is question and answer. Welcome to you all to raise your question during question and answer section. Now, please allow me to give a brief introduction of webinar moderator, Dr. Abdallah El-Sayed Allam. Dr. Abdallah, he studied Faculty of Medicine, Rheumatology, and Rheumatology at Tanta University at Egypt and earned his medical doctoral degree in 2020. He is a co-founder of Egyptian Society of Musculoskeletal and Neuromuscular Sonography and Arab League of Musculoskeletal, Neuromuscular, and Spine Ultrasound. He's a professional expert in application of rheumatology and rehabilitation. His current work in famous institutions such as Armed Force Rehabilitation Hospital at Al Cairo at Egypt and Morphological Madrid Research. I hope I read it right. At Madrid in Spain. He has done a lot of training, such as ULAR Musculoskeletal Ultrasound course in Paris, 2014, and fellowship in Ultrasound Unit Department of Physical Medicine and Rehabilitation, National Taiwan University, in Taiwan, 2015. This is a brief introduction of Dr. Abdallah Allam. So let's welcome Dr. Abdallah.
Thank you, Mr. Hisham. It's a pleasure to be with you today. It's my pleasure to introduce my mentor and teacher, Professor Dr. Adham AboulFotouh Khalil. Please share the slide of Dr. Adham Hisham.
Okay. Just a moment. Yes.
My teacher and brother, Dr. Adham AboulFotouh, studied at the Faculty of Medicine, Cairo University, Egypt. He had postgraduate studies at University of Bath, United Kingdom. He is fellow of the American College of Rheumatology, a certified musculoskeletal ultrasound trainer. He also had a fellowship training on musculoskeletal ultrasound in Spain. He conducted extensive teaching programs in Egypt and 10 other countries. He introduced training programs in Egypt in most of the universities and hospitals in the field of musculoskeletal neuromuscular ultrasound. He participated as a faculty and tutor in many ULAR courses and ULAR courses and international courses. He is arrived shortly from Jordan, conducting an intensive course there for Jordanian rheumatologists. He is the president of Egyptian Society of Musculoskeletal and Neuromuscular Sonography and scientific director of the Egyptian School for Musculoskeletal Ultrasonography. He promotes structural as well as focused ultrasound training with a special interest in multidisciplinary activities and cooperation, like cooperation with pain physicians, cooperation with physiatrists, cooperation with orthopedic surgeons, plastic surgeons, neurosurgeons, and other specialties interested with musculoskeletal ultrasound. He is a consultant of internal medicine, rheumatology, musculoskeletal and neuromuscular ultrasound with wide range of published papers and book chapters. He was honored twice by the Egyptian Medical Syndicate as well as by many universities. It is my pleasure today to introduce him. He is best Egyptian sonographer. I don't mean sonographer technician, no. physician who practice the art of ultrasound in the field of musculoskeletal and neuromuscular ultrasound. Please, Dr. Adham, you can share your slide and take us to a journey, beautiful journey as well.
And second to Hisham, a long-term partner with our activities and always a hard worker.
It's my pleasure.
Thank you so much. But now I want to thank Dr. Abdallah. He's not only my colleague or a friend, he's a dear brother. I've known him for more than 10 years, and we have been working together. He's a very peculiar and very special, recognized international figure. And I have the honor that I was the first one to tell him that you will be an international figure.
Yes.
Thank you so much. He mentioned 2 points that are very, very important. One about the multidisciplinary approach and the cooperation with the different specialties. This is a very good deed to do, and I advise everyone to do the same. We grow together. We are better as a team working in this specialty, especially that I have been working in this field since it was evolving. And now there are some establishment done that necessitates that we always cooperate together for the future. I really appreciate this very nice introduction by my friend, Dr. Abdallah, my friend and brother. Thank you so much. And now I will try to share my screen. Today, like he said, the second thing that I wanted to say, that he said a very nice thing, that it's a journey. No one in 50 minutes or even in 2 hours can mention everything about rheumatoid arthritis using the ultrasound, but it's my point of view. It's a kind of a journey, so try to enjoy, and please write down your questions to answer them at the end of the presentation. I will now just go like this. Can someone confirm that you can see a full screen with a laser pointer?
Yes.
Yes, let's work right now.
Excellent. So we will go ahead without a delay so that we don't waste your time. Thank you so much for all the participants who decided to take their time to attend my talk about the rheumatoid arthritis. I really appreciate everyone's attendance, and I hope you find this useful and keep your questions till the end. You remember that the ACR-EULAR 2010 classification criteria depended so much on serology, positive ACPA, and rheumatoid factor, of course, for 50% almost of the diagnostic criteria. So it has became easier to diagnose the seropositive rather than the seronegative rheumatoid arthritis. Now, the advanced imaging techniques, namely MRI and musculoskeletal ultrasound, could provide an extra tool for the clinicians for these more difficult cases by revealing some features typical of rheumatoid arthritis, including synovitis, effusion, tenosynovitis, erosion, and a lot more like cartilage affection, follow-up of the disease, guiding local interventions, and so forth. And of course, for the MRI, it also includes an additional showing bone marrow edema early in the disease. This is a fairly recent paper published in 2020, mentioning that the rheumatoid arthritis is no longer considered a fixed phenotype, but rather a disease continuum. It's like a process. We have a preclinical phase and then clinical phase. And during this clinical phase, we also have a continuum of an exhibition. The musculoskeletal ultrasound, being a real-time diagnostic tool, is very nice at showing this continuum, even starting at the prediction of the disease for those at risk, or showing subclinical synovitis, or following up the disease, and so forth. We will see that. Remember, those people at risk, when they are at risk, means smokers, genetically susceptible, relatives of rheumatoid arthritis patients, and so forth. those patients or those people at risk, when they develop clinically suspect arthralgia, we have a very significant useful tool of the ultrasound usage on those patients. This is a very nice a very nice paper that is by clinical examination. So they predict the development of the inflammatory arthritis, and that's why they improve risk stratification and management of those patients. What about the patients with early undifferentiated arthritis? Every day we are faced with those patients at our clinic. So the ultrasound can predict the development of persistent arthritis, mostly rheumatoid arthritis, and improving early diagnosis and access to treatment. And also, there will be included a slide like this one about the differential diagnosis, how to use the ultrasound for the differential diagnosis of the rheumatoid arthritis, especially in early rheumatoid arthritis. What about the patients with established rheumatoid arthritis? We have the tool of the ultrasound to assess the response and therapy evaluation of these of the new symptoms, and integrating the ultrasound into the clinical centered monitoring strategies or guidelines or criteria is really important and useful. Now, for the individuals in remission, according to, for example, the DAS28, DAS28 ESR or whatever, we can detect with ultrasound subclinical synovitis, subclinical inflammation, like using combined grayscale and power Doppler. And there is some studies that correlate this to prediction of progression of structural damage or prediction of disease activity. Now, regarding those subclinical synovitis, this is a very common saying. And in the earlier times, we used to be faced with the fact that people ask questions. How do we know that this subclinical synovitis is significant? Subclinical synovitis means the patient is at remission. We detect activity by ultrasound. So many studies have shown that anti-CCP positive individuals with some musculoskeletal symptoms and no clinical synovitis, they have subclinical inflammation detected by ultrasound, especially when you combine grayscale and power Doppler. It becomes more specific. And this is associated with the development of inflammatory arthritis, both at a joint level and then at a patient level. And this is a very peculiar differentiation. Is it relative? Well, yes, there is a potential clinical relevance of subclinical synovitis that is highlighted by studies in rheumatoid arthritis, despite being in clinical remission. They don't achieve good functional outcome. I don't know about the age or the median age of the participants, but I come from an era where we used to use gold for treatment of rheumatoid arthritis and methotrexate. That's all what we had at that time. And we used to do a plain X-ray for the hands and wrist every year to follow up. And when the patient was saying, I am getting better, we clinically see that he's better. His lab tests were better. He still developed some deformities a year after the other, while we could not do anything about it. The ultrasound, I think, can detect this very quickly, very early, with the persistence of the subclinical synovitis that can lead or consequently cause those deformities. In the rheumatoid arthritis, the ultrasound can show synovial diffusion, synovial inflammation, bone erosions, and then cartilage assessment, guiding local injections if we need, and because we need this sometime, and then disease monitoring, which is this sensitive area. Disease monitoring means if the patient, I can detect a patient at remission with subclinical synovitis detected only with ultrasound. I can do patient monitoring to set a start point for biologics, an end point for biologics. We can see subclinical synovitis in patient drug-free interval. When he develops activity by the ultrasound, this predicts inflammatory arthritis flare later on. So interfering earlier is much better, and so forth. Now for the scoring systems, we have this very nice paper by Emilio Filippucci and the group in Italy that showed that we can see synovitis whether by grayscale or by Doppler. By grayscale, we can see effusion and hypertrophy. By Doppler, we can see vascularity. Now, remember this scheme that at that time, synovitis by the grayscale included effusion, because recently this has been opposed and now it's different. But remember that with grayscale, we can see both elements, the power Doppler combined with the grayscale ultrasound or the MRI are useful in subclinical synovitis, and that subclinical synovitis of the small joints of the hand can progress to bone destruction. This is what I was talking about a minute ago, when at this era, I used to see the patient developing deformities, and we cannot know why. He's in remission. We think he's better clinically. His labs are better, but probably if we had the ultrasound, it would have shown activity. In 2017, the Euler standardized procedure for ultrasound imaging in rheumatology was published, and this one has recommended few things using the ultrasound. First, that we can use the beam mode and the color Doppler, so it's a grayscale and power Doppler. And then it recommended the use of higher resolution linear transducers. In the beginning, it started to be below 10, and now the high frequency or high resolution, meaning above 10. At that time, maybe it used to be maximum of 14. Now we have very commercial up to 18, 20, 22 for the superficial areas. Now, each one of those are very important characteristic of the machine to add a tissue harmonic imaging, compound imaging, panoramic imaging, trapezoid image or virtual convex. All those are software capabilities. And don't think less of the software capabilities, because it can improve the image quality very much, even if the ultrasound machine is capable enough. So you have to get yourself acquainted with the machine. You have to know the different techniques, some primitive physics of the ultrasound machines, and some knobbing or special settings. Those are very important. Even if you're a good sonographer and you have a good machine, you will need those to improve the image. And of course, they continued with enumerating the advantage of using the ultrasound and how to set up the environment for it, including that the ultrasound is the only dynamic modality to scan. Neither X-ray, CT, MRI are dynamic or frequently used as dynamic. This is an example of how to visualize the tibial joint at the ankle. This is the anatomy, and this is the ultrasound zone anatomy. So the tibia, the talus with the overlying hyaline cartilage, and then the overlying soft tissue components. So you can easily tell the difference between the one on the left, which is normal, and the one on the right that represents an abnormal material intra-articularly that distends the joint capsule. Now, this is another view of a small joint. It could be an MCP, it could be an MTP that shows some effusion. Just by applying a little bit of compression, we can see here a complete compression of the abnormal material inside the joint with complete displacement, confirming that this is completely a fluid. But you have also at the periphery here some synovial hypertrophy. In this case, I would say that the major component would be fluid with some shy synovial proliferation. Of course, applying this compression is part of the fact that the ultrasound is dynamic and the fact that the ultrasound is real time. So you can interfere, you can customize, you can compress, and use all these techniques to help you with the diagnosis. Like I said, you cannot do this with the other scanning modalities. Here we have an example of a normal hip joint. As you know, this is the head of the femur, then going to the neck. This is the capsule reinforced by ligament. And this is a joint recess which is collapsed. You can see the capsule here parallel to the neck of the femur, while here you can see an abnormal material intra-articularly distending the joint capsule up. And even in this area, which cannot be easily detected clinically, you can see it very well with the ultrasound. You can also grade this with the ultrasound. You can also direct your injection easily with the ultrasound. Another example in the wrist joint, everyone knows that at the beginning of wrist examination, we put the probe in the midline longitudinally on the dorsal side of the wrist just to detect the joints and the tendons. Here we can see the radiocarpal joint, the midcarpal joint, This is radius, this is lunate, this is capitate. And then we can see that the down figure here is shows a very abnormal intra-articular material and some bone deformities or erosions. The capsule is distant, and it can differentiate here. So in grayscale, we have both joints in activity. In power Doppler, we have a peculiar prediction here with the mid-carpal joint, probably much more than the radiocarpal joint. So, like I said, always combining the power Doppler with a grayscale can be very beneficial. But remember that having a positive Doppler is a very good specific test, and it adds to the precision of the ultrasound. But having a negative Doppler does not nullify, does not neutralize the presence of synovitis. Because there are so many reasons why Doppler can be negative in some active cases. This is another example where you can put the probe longitudinally on the MCP joint, detecting the metacarpal head, the base of the proximal phalanx, and see a normal joint. Here's the anatomy, having the tendon, the capsule, and the two bones constituting the joint. Here is the abnormal joint. You'll be amazed once you see a rheumatoid arthritis patient involving MCP joint with a lot of arthritis, synovitis, and distending the joint capsule. This recess of the recess of this joint is really huge, and here we can see even the extensor tendon being strained by the synovitis, and here you can see even bone erosion. Of course, as always, adding the power Doppler can confirm that you have an abnormal material that is synovial hypertrophy in the joint. Not only, but you also have here an active erosion that involves pannus that is eroding in the bone, and then the neovascularization being detected by power Doppler, giving a picture of active or hot erosion. Another example for the PIP joint that we all also think that it has a small recess. No, on the contrary, on the right side, we can see a mere effusion with the joint, but also with this one, we can see more effusion of the PIP joint. And then if you apply a power Doppler in another case, you can see a lot of power Doppler inside with a lot of abnormal material distending the joint recess. It will show you how big is this PIP joint and how much criteria of rheumatoid arthritis can see. Probably erosion, irregular bone line, synovitis by grayscale, hypertrophy that is being irregular and heterogeneous, and then a positive power Doppler. And you can also, of course, confirm your diagnosis or monitor your patient. This is another example where we can see a longitudinal view on the lateral side of the elbow, having here the capitulum of the humerus and then the radial head. This is the radial fossa, which we see distended with fluid when we have just small amounts. If we have big amounts, everything will be distended. This is an example. So here we have a small amount of effusion, but always remember that when you see this, you have to do a tilting maneuver of the probe, because this can be a result of anisotropy. Everything in the soft tissue can show anisotropy. So if you are not perpendicular to the structure, like tendon, like capsules, like even fat pads, and some nerves do this, you need to be perpendicular. All these soft tissue components, they just differ in the degree of showing the anisotropy, but eventually everyone will show. Here I try to do dynamic examination, some tilting, some compression, just to confirm the presence of effusion. Here you can see the joint that looks normal, but here you can see this amount of fluid that can be very beneficial. When you have a lot of intraarticular abnormal material in the elbow is really a big joint that show the distension of the capsule. What about the intra-observer reliability of these findings? Well, for the synovitis and the effusion, it's more than 90% agreement on the inter-observer reliability. So that's a very good or excellent tool. This is adopted from Esperanza Naredo that once enumerated some of the full image of the scoring system for synovitis. So all these people, all these papers suggested synovitis scoring. And remember, synovitis or synovial hypertrophy can be element that can be graded. So if you include effusion, that's an element. Hypertrophy, that's an element. Erosion, that's an element. If you combine those, so you can do a score for one joint. If you combine few joints, you can include all the elements in one joint and then count the joints and make an overall global score for the patient so that you'll be able to diagnose. For example, let's take semi-quantitative scale for effusion and hypertrophy. This is a normal joint. Here we have a very tiny effusion. Here we have moderate effusion, and here we have marked effusion. Okay, everyone has a definition. So the marked effusion, we can see an elevation of the joint capsule. It's not left to our judgment completely. However, this is a semi-quantitative score, and I think it's one of the most common ones and most old ones used. And then at the end, they made the sum scores of synovitis from MCP 2 to 5 and PIP 2 to 5, and they collected the data from all these joints, because having one joint, again, having one joint with an inflammation is not enough to diagnose the rheumatoid. So this is the grayscale scoring with mild effusion, moderate effusion, and then here we have convex even capsule that shows marked effusion of the joint. Again, there is a correlation of the synovitis detected by ultrasound with a lot of other data. For example, it correlates with the histology of those synovial hypertrophy removed surgically. It correlates well with the increased with the clinical examination. The power Doppler correlates well with the treatment or the changes done by the treatment of the rheumatoid arthritis by biologics. It can predict the radiographic erosion, and the ultrasound actually detects the erosion much more earlier than plain X-ray, and probably that would help you if you were in my era seeing the patient developing deformity a year after the year while clinically he is getting better. The power Doppler can also correlate with bone marrow edema in the MRI, and then it detects if there's an activity in clinically remission patients, and also with ongoing synovial inflammation, and then it predicts the clinical relapse. This is a lot of important information. For the power Doppler, you can also grade your power Doppler. First, they said that you have 1 or 2 points, and then I will show you how this score is now different, but at least having a mild score, moderate score, and then a marked score of the joint, you can see the same radiocapsular joint here with different power Doppler scores. The power Doppler, when positive, adds a lot of information and can increase the accuracy of your finding. I will choose one paper and one score of those scores I told you about when you evaluate the rheumatoid arthritis patients. A lot of times we get asked, how can we diagnose a patient with ultrasound, diagnose a patient with rheumatoid arthritis with ultrasound? If you are suspecting this, you can examine those 7 joints, for example, with second and third MCP, second and third PIP, second and fifth MTP, and then count the 7 joint scores. And this joint, of course, you can scan those joints for abnormal material, synovitis, erosion, and so forth. This is a paper I participated in when we had studied the validity of this 7 joint score versus simplified 12 joint score, and we found that this 7 joint score, especially when combined with power Doppler, especially if you include the tendons, have a very good correlation with disease activity and a very accurate detection of rheumatoid arthritis patients, and probably saving you the time of doing 10, 12, or 60 joint score, for example. This is another paper that studied the Rheuma truck screening and awareness initiative, and that means screening tool to detect early rheumatoid arthritis for those patients. So while this ultrasound score of 7 was very frequently found in healthy persons, meaning that you can have some activity in 1 or 2 joints without having clinical information or clinically important information, but having a score more equal or more than 5 with this score is really highly predictive of initial diagnosis of rheumatoid arthritis. Now remember that in 2017, when the Euler Omer Act Committee released the for synovitis, but it can be seen with grayscale even in the absence of Doppler signal. But the existence of synovial effusion alone is now not sufficient to define synovitis. They think that we can have a synovial effusion for many other reasons. This is the paper that was released by the Omer Act Euler Committee, and and those are examples of the grades. So first they put a grayscale grade, and they put a power Doppler grade, and they combine the scores together. So this is a normal. You can see the green triangle that is formed by the capsule and all the supportive connective tissue. And then here we have a mild synovial proliferation that did not exceed the bone level, and here exceeded the bone level to go above the bone line. And here you have a convex score, a convex capsule. As well here, you have negative power Doppler, minimal power Doppler, moderate power Doppler, and then a marked power Doppler. I wanted to say that here, even with a grayscale, you can detect major synovitis, but it has a negative Doppler. So it's sometimes important to combine the score. That's the very important one. If you depend on the Doppler in this image, it would be negative, but with grayscale, he has marked or grade 3 synovitis. So it's always important to count both. Now, how does this go? It goes with the higher rating. So if you have a grayscale of 1 and Doppler of 2, then the grade is 2. And vice versa, if you have a grayscale of 2 and the power Doppler that is even 1 or 2, it's considered a grade 2. So that's the usefulness of adding the power Doppler to the grayscale and make a combined score. This is a description. So for example, grade 1, what is meant by synovial hypertrophy with grayscale? So it's hypoechoic, minimal, up to the level of horizontal bone line. And then with the power Doppler, you can have either single Doppler, you can have one confluence spot, means a bigger one that is consistent of few spots, and then or 2 single spots or up to 2 confluence spots. All these variants are considered a grade 1 by power. What if you had this minimal change with the synovial hypertrophy and no power Doppler? It will take the higher rating. So it would still go, it's 0 with power Doppler and 1 with grayscale. So it's considered a grade 1 or score 1 for the combined score. Here's an example where you have, for example, grade 2 by grayscale. This is considered grade 2. This is considered grade 2. What if you combined this grade of the power Doppler with this grade of grayscale? It would be upgraded to grade 2. So it would take the higher score as the combined score is beneficial in this area. Now the validity, again, another paper with validating the subclinical synovitis, and it has been recommended as a standard treatment to target recommendation by most rheumatologists working with the ultrasound. This goal is achieving remission. As you know, remission is the mission, and it's very important to use the ultrasound to detect this. So again, this is a quick review of some patient scoring. Now, this is a patient level scoring that detects 12 joints, 3 joints, 7 joints, 8 joints, 10 joints, and so forth. And like I told you, we have evaluated this score, a 7-joint score done by Marina and the other colleagues. And I have the honor to have participated in one of the studies that studied the reliability of the score and found it very reliable. Now, the element of tenous synovitis is also involved in rheumatoid arthritis. This is a patient might be with chronic synovial proliferation of the hands, of the wrists, and you can see some deformities, you can see some swelling clinically, but probably it's quite difficult to differentiate which element is taking the major affection, because you can see some changes in the joints, but the major change was in the tendon, and you can decide with the ultrasound which tendon is this, which group, and how can you interfere inside the tendon, and some starting tendon erosion here. So it's very useful tool to judge not only the presence of synovitis, but which element and how far do we go with this. Tendinosis or tendinopathy, tenosynovitis, tendon erosion starting. So, and here you can see that we have no very well demarcated outside border of the tendon, and that the synovial proliferation might be invading the border of the tendon, and then this tendon can be subjected later to tendon tear. This is a transverse view or short axis view of the tendons, the flexor tendons at the hand, where we have an increased cross-sectional area. It's an increased size of the tendons. And here you can also see some synovial proliferation with Port Doppler signal of the flexors. This is a cross-section here at the flexor tendons of the fingers, short axis view, and this is very peculiar tenosynovitis. Another view, probably at the ankle level, medial side of the ankle, where you have the tibialis posterior and then flexor digitorum longus, where you can see some fluid and proliferation of the synovium in the tendon sheath, above and below in the longitudinal pattern, all around in the short axis pattern. And this is a dynamic examination where you can even ask the patient to move his fingers while you're studying the movement of the flexor tendons, and you can see the distended tendon sheath and the movement of the tendon. This is very useful because this might have a differential diagnosis sometimes, where you can see triggering, where you can see tendon tear. Is it involving both tendons or one of them? Is there any tear, or is it just adhesions or synovial proliferation, or even poly thickening that is triggering the tendon? This can be very well and quickly seen with the ultrasound. This is even an image that can detect longitudinal tear inside the flexor pollicis longus. So it's no more cut in half, but there is fraying of the fibrils inside and separation of the fibrils. And we call this longitudinal tear or intersubstance tear that can later on develop into full thickness tear. The extensor carpi ulnaris at the ulnar side here at the wrist is very important tendon that can be involved in the rheumatoid arthritis. Not only this, but we can detect near this styloid process of the ulna, a bone erosion, together with this tenosynovitis of the extensor carpi ulnaris. Both are very significant at the rheumatoid arthritis patients. Here you can see the longitudinal level. Here you can see the short axis view. All of them would show bone erosions, abnormal tendon, and then abnormal tendon relief. This is quite a dynamic examination where you can see the tendon normal at one stage and abnormal. This is a normal image, then abnormal image. Here you can see the abnormal part longitudinally. All these bony parts, despite having usually normally irregular contour, but here you can see a very well-known erosions together with the tenosynovitis of the extensor carpi ulnaris. This is a study of the reliability of the semi-quantitative scoring done by the Euler people, Speranza Naredo, Di Costino, and Wakefield and et al., all the people, where they have published the Omer Act scoring, semi-quantitative one with normal tendon, grade 1 tenosynovitis, grade 2, and grade 3. Again, just like the tendons, it's a semi-quantitative judgment of the tenosynovitis, and this one for the longitudinal one. So here you have a normal tendon, here you have a mild distension of the sheath, moderate one, and then a marked one. So you can grade 1 to 0, 1 to 3, or 0, mild, moderate, marked. This is the Omer Act for the transverse view of the tendon with a power Doppler, and then with a power Doppler for the longitudinal view. Again, 0, 1, 2, 3, or 0, mild, moderate, and marked affection. Of course, like I told you, the Doppler can be helpful. Here, if you move the probe proximal, distal, you can see the tenosynovitis of the wrist. So the video started with, again, a normal view. I will show it again. Normal view with the tendons. And then here, when we go distal, you can detect an abnormal view with tenosynovitis. This is the fourth compartment. Following those structures and scanning them along their course, very important, because you can detect the pathology in a different fashion. Now, if you scan proximal, this is the distal ulnar joint here that is distended with abnormal material. Could not detect this when we had the anatomical landmarks, but moving your probe proximally can detect these abnormalities. Very early, David Kane at 2004 published this paper about depicting very small erosions, and probably those big ones might be detected by plain X-ray, but those small ones are not detected by plain X-ray. And then later, Ahmed Zayat and Richard Wakefield in Leeds, they have proposed a new bone erosion scoring system that divided the metacarpal head into 4 and divided each quadrant into 3, and then they count the bone erosions depending on how big the bone erosion is covering this quadrant surface. So 1/3, and then 2/3, and then all the quadrant, and then you summate all these by the joints, and then you sum together. Why is this used? Because the previously, we used to say that we have a very small erosion below 1 millimeter. And now with the advancement of the machines and the techniques, we can easily see very, very small erosions, even less than 0.5 millimeter or even 0.1 or 0.2. So probably having a newer bone erosion scoring system is advised. But it's just a brainstorming to tell you that you can use scoring system, whatever one you use. There is a scoring system for synovitis, Doppler signal with synovitis, tenosynovitis, Doppler signal with tenosynovitis, and then a bone erosion. This is a study done by Wakefield. Even at the earlier ages of 2000, there was an easy detection on the number of erosion, 6 to 7 times more than the plain X-ray early in the disease, where the plain X-ray might not be enough to detect the erosions. Even late in the disease, you can still see more erosions with the ultrasound than the plain X-ray. What about the cartilage lesions? You can even do dynamic examination of something like metacarpal head with the overlying hyaline cartilage to detect the cartilage changes in rheumatoid arthritis. The ultrasound is a very nice and peculiar tool in doing this. It's the only real-time one. It's the only dynamic one that you can use your movement, the probe movement, or the patient movement to check and examine some structures. Emilio Filippucci at 2010 suggested this score for evaluating metacarpal head. As you know, the Italian group are very peculiar working with the ultrasound on the cartilage. My mentor and professor, Walter Grassi, he studies only the cartilage in the hand. And it's funny when he says, I only study the second MCP joint cartilage. So it's a gradual thinning process that involves the cartilage destruction. This is an example where you have a metacarpal head cartilage of 0.4. If this is an old patient with rheumatoid arthritis, it would have been acceptable. But you can see 0.31 and you can see a 0.2. So if this one is a young female patient with rheumatoid arthritis of recent onset, it would be a disaster. So we have to be careful. This disease is very aggressive and deforming. This one for an old patient is okay for this thickness. Again, you can apply power Doppler and you can see that the pannus formation with neovascularization is invading into the erosion, how it invades from the synovitis into the bone, forming a bone erosion. This is another reliability study that involves osteoarthritis and the cartilage, and this one is published with an excellent or at least very good reliability of the cartilage variation and development. My colleague and friend, Violet Avlap, she published this ultrasound, just to remind you, because we always check the dorsal aspect of the hand to detect the synovitis. she just peculiarly showed that in some joints, like the second MCP, we sometimes detect a volar affection more than the dorsal affection. Although that I know that you might be judging a normal joint as synovitis, but really in some touch on the dorsal aspect of the finger. Now, this is a paper, a very nice one also, published regarding the strengths and the weaknesses of each of the ultrasound and MRI. So, for example, the ultrasound cannot penetrate into the bone, and the temporal comparison is difficult. Temporal comparison meaning time comparison, although I have to say that it's now easy with some machines to bring out old studies and show the new image, and then you can tell the difference. It's mostly operator dependent, but with very similar qualifications and years of practice, you can easily get a very good inter-observer reliability. However, something like the MRI has a lot of contraindications. It's time consuming, and there is less of patient tolerance to it, and it's limited to one body region at a time. You cannot really compare like using the ultrasound. It's not so difficult. It's not so easy to do it. Here are some images using before and after. So, for example, this is the lateral side showing the subtalar joint. So I assume this is the fibula, and then the talus, and this is the subtalar joint. And it showed synovitis. This joint is very nice when it showed abnormalities. After the treatment, whether it was an injection, you can get complete remission of this patient, and you can even see some or minimal fluid at the fibula-talar joint, but complete remission of the subtalar joint. Here you have synovitis at the wrist, where you have the ulna, the radius, and the fourth compartment of the extensor tendons with tenosynovitis and positive power Doppler. And then after treatment, it goes back to normal. It's very nice to check with your ultrasound the degree of improvement. Here is a deep point where you cannot really see or detect clinically diffusion with easiness, but with the ultrasound you can see it was with diffusion, and then after treatment completely normal. Even the most easy diagnoses, like olecranon bursitis, were used to get this clinically very easily. This is an example of a video that shows a needle trying to aspirate and inject olecranon, where you find that there is a villus hypertrophy of the synovium of this bursa that might obliterate your needle and hinder even aspiration of the most easy diagnosis. This is a Baker cyst where you put your needle and they cannot aspirate a minimum of 1 ml from this bursa. Why? You will know now. Because when we started to inject, it goes like a tree because it's full of synovial tissue, and this can show you your progress, your even anticipation in the future. What do you expect from this Baker cyst, for example? Can you see it's full of synovial proliferation? Not only it can help you with the diagnosis, but it also can help with it can also help with the follow-up of those patients. Now, what about the injection? Can you imagine that this is a tenosynovitis of a big tendon at the ankle? So we know that the tendons around the ankle have a minimal effusion acceptably because of the gravity. And then when you have tenosynovitis, you will find why it's extremely difficult to judge the tenosynovitis of the to put the needle in this tenosynovitis and inject. Why? Because this space of the tendon sheath distension is less than 1 millimeter, and it's very difficult to blindly put your needle here. If you have the ultrasound helping you, it would be like you see. You can guide your needle here. It's gone. You can change the angle. You can direct it at the tendon, distend the tendon sheath that is less than 1 millimeter in thickness. You will know you're right when you find your medication of injectate spreading above and below, so you can see it here. Although that the needle is here, you can see the fluid underneath, which means you're correctly placing your injectate inside the tendon sheath. You cannot really do this. I wonder what we were doing blindly. Now, some differential diagnosis quickly. This is a very fairly recent paper, a very nice one that can show you what to do with undifferentiated arthritis that comes to your clinic every day. So, a foreign body a few days or weeks earlier, so you can detect septic arthritis with ultrasound. Another thing is, if you concentrate on enthesitis, a palmar plate inflammation early in the disease, probably a collateral ligament inflammation, this will take you to the spondyloarthritis. What about a patient that is not young, probably above 50, maybe above 55 as well, with bilateral shoulder that involves subacromial subdeltoid bursitis and probably biceps tenosynovitis, and then a hip affection and no wrist affection earlier? So this can take you to the polymyalgia rheumatica. What about a detected synovitis in some joints? Are they symmetric distribution with erosion and tenosynovitis? They will take you to the rheumatoid arthritis. Are they asymmetric or probably less synovitis and more double contour and more crystal aggregates, or probably seeing a tophus? This will take you to the gout. What about the synovitis that together you can find chondrocalcinosis or tendon calcification? This will take you to the CPPD, of course, with a suggestive age, probably about 55 or 60. Now, what about clinical features suggestive of connective tissue disease, or even ultrasound with the synovitis detecting calcification or calcinosis? This is a mixed connective tissue disease, and so forth. So this paper I recommend very highly. It's a very nice algorithm to use the ultrasound very early in undifferentiated arthritis clinic, and you know that it's sometimes very recommended to use the ultrasound on those clinics. Differential diagnosis with using the ultrasound regarding the comparison between rheumatoid arthritis and gout. Now, which group would have more synovial hyperplasia? Rheumatoid or gout? Well, it's clearly rheumatoid, that is yes, with synovial hyperplasia, and clearly gout, less yes and more of a no to the synovial hyperplasia. It doesn't mean you cannot see gout with synovial hyperplasia, but probably you can count the patient score rather than one joint. So if you have 6 or 7 joint score on one patient, probably you can see 5 with the rheumatoid arthritis with synovitis, and probably 1 or 2 in the gout, maybe. Again, this is the shape of the synovium with the snowstorm appearance and probably the starting with double contour and some shiny crystals, while in rheumatoid, it's a heterogeneous material with indistinct bone erosion that is the rheumatoid arthritis. Another example where you have Doppler signal on both, but you can see here an unclear boundary with rheumatoid arthritis erosion with a pannus formation invading inside. What about the erosion itself? Now, the clear boundary is seen in the gouty group, while blurred boundary is seen more in the rheumatoid arthritis group. Because even at the x-rays, you know, they have taught us that you have a punched out erosion, there's a rat-eating erosion, it's a big erosion. Even with the ultrasound, you can detect a clear boundary in the gouty group and the blurred boundary in the rheumatoid arthritis group. Here's an example of a blurred boundary. Here's an example of a very big and distinct boundary erosion in rheumatoid arthritis. So you can see this is blurred. This is even questionable, because here we have a notch. Is it a notch? Is it an erosion? But here you have a very clear cut and a clear boundary erosion of, can you see? Punched out erosion, very big one on the medial aspect of the first NTP in gout. What about the differential diagnosis with psoriatic arthritis? In psoriatic arthritis, we have a primary enthesitis. So even if you detect synovitis in the joint, it's usually enthesitis that is taking the upper lead, that is rarely affected early in rheumatoid arthritis. In rheumatoid arthritis, you can see it's primary synovitis with peri-articular erosion, while here you can see a primary enthesitis. Remember, it's the primary affection of synovitis in rheumatoid arthritis, and that secondary enthesitis, while it's the opposite, the enthesitis that affects the peri-articular and some entheses away from the joints as well, like patellar tendon, like Achilles, like plantar fascia, but they have nearby synovium to form the synovial enthesial complex. which is beyond the explanation today. Today we're speaking about the rheumatoid arthritis, but this is a very rather usual comparison because in the undifferentiated arthritis early, there's always conflict between is it rheumatoid arthritis or spondyloskeleton plus the sacroiliac joint and the hip joints affected. In psoriatic arthritis, you have both, so it can be peripheral, but you still have some spine or at least sacroiliac affection. But you can also find a lot of small joint affection peripherally. So this will differentiate between the spondylo in general, which only is specific for the spine, the sacroiliac, and the hip, or between the, again, another pattern which is bilateral symmetrical, but spares the spine usually and the sacroiliac joint. For the reactive arthritis, mainly, as you know, in the lower limb and polyarticular or oligoarticular, it's a very nice algorithm published in this paper. Needless to go through those because we used to learn this long ago where we had some similar clinical picture, but very different treatments, measures, and research criteria for those two diseases. And if you take an affection of MCP joint, it would predict the affection in rheumatoid arthritis. If you have a very early tendon, like extensor tendon affection over the MCP joint, this can favor the psoriatic arthritis. So synovitis is more common in rheumatoid. You can see both diseases have this element, but more peculiar with the rheumatoid. Affection of MCP dorsal extensor tendon is more commonly affected in psoriatic than rheumatoid, 50% in psoriatic versus 2%. That's early in the rheumatoid. The soft tissue edema and the dactylitis is fairly exclusive for psoriatic arthritis. So it's very nice to know with the ultrasound when to use it, how to use it, on which to use it. I will not go through this differentiation because everyone knows that. Which joints, is it polyarticular, symmetrical, asymmetrical, which joints to affect? If there is enthesitis, it would go to the psoriatic. High titer of rheumatoid factor would favor rheumatoid arthritis. Which gene alleles, nail lesions would go to the psoriatic arthritis. You have a skin psoriasis that makes your life easier, and so forth. The conclusion is a better validation of the ultrasound criteria of remission. That means we have to include, if you need to be strict about the remission criteria, then you have to include ultrasound findings for these remission criteria. I would thank you so much for attending to me today, and we'll wait for your questions. This is our Facebook group. This is the YouTube, not so important now medically. This is my email, this is my phone number, and this is a picture of the pyramids that says hi from Egypt. I personally took that from the plane when we're having a take around when the airport at Cairo was busy. I thank you so much, and I welcome your questions.
Thank you so much, Professor Dr. Adham AboulFotouh, for your masterpiece presentation as usual. And now questions is open, and I hope the attendants ask questions related to the presentation. I see a question asking about the best treatment for patellofemoral pain.
Well, patellofemoral pain is beyond this presentation, but I need to say that it's the most common presentation in the orthopedic clinic, or it can be actually mechanical rather than inflammatory. There's a lot of targets that can be affected. Even the mere subluxation that is biomechanics affected can make this pain. Affection of patellar tendon, quadriceps tendon, runner's knee, jumper's knee, affection of the retinaculum, subluxation of the patella, patellofemoral, I would say chondromalacia patelli, plus the usual synovitis and so forth of the rheumatoid arthritis. So there's no specific treatment for all these cases. Each one has to be treated, but you can use your ultrasound and your clinical examination to determine what is your specific diagnosis, and then you can decide on how to treat.
Thank you so much. As a second question, also is outside the scope of the presentation, someone asked what are the contents and skills of sacroiliac joint examination.
Okay. Sacroiliac joint is partly fibrous, partly synovial. So it's a mixed joint, and it's beneficial to use the ultrasound to inject. That's well known for everyone. Sacroiliac joint affection. Why? Because it's known now that you can easily have pain coming out from this area, but it would initiate or come from the ligament, the overlying muscles, nearby nerves, or even the enthesis that of the insertion of the muscles into the pelvic bone. They all can imitate or camouflage as a sacroiliac pain. So there was a need to use a modality that is easier than the MRI to detect the ultrasound, to detect the synovitis in the sacroiliac joint. Now, using the ultrasound is not straightforward, and there's no consensus on how to use it, but there has been papers published. It depends on how much the grayscale thickness of this area below the ligament, and then how much power Doppler can you detect, and especially using resistivity index on the power Doppler can increase your sensitivity and specificity for a sacroiliitis. But I need to say that it's not straightforward. It's difficult. It needs a very experienced user. It needs a very good machine. And the standard thing is that you can use the ultrasound for detecting the joint and guiding injection into it.
Thank you so much, Dr. Adam, for your short, comprehensive answer. There is another question asking about drugs available for joint cavity injection. Drugs available for joint cavity injection therapy for rheumatoid arthritis.
Well, there's a lot of things you can use. For example, the straightforward one is the steroid local anesthesia combination. And then you can use PRP, and you can use other injectates. Mainly, if I think there is an indication for, there is a less expected side effects of the injection, like inside the joint. I personally would prefer steroids at that time. But when you have a combination, like this patient would have osteoarthritis as well, then after the remission, I would choose another thing like regenerative medicine, PRP, hyaluronic acid, or otherwise. And there is, I remember a paper that was published by yourself, Dr. Abdallah, about even using the methotrexate and some use of botulinum toxins in some injections. So a lot of injectates are available. But I suggest if you have a single injection that is safe done in a joint, in an inflammatory disease, personally, I would prefer steroids to begin with, and then you can choose another one later if you need to. I should probably stop.
Thank you so much, Dr. Adham AboulFotouh, for your comprehensive short answer. Another question, I examine a case of tarsopharyngeal joint erosion with synovial hypertrophy grade 3 by B mode, no definite vascularity by power Doppler, only the left third metatarsopharyngeal joint is affected for 4 months. Please, your opinion. He is young, active male with no significant medical history.
Of course, we cannot judge the disease itself, but if you're doubting a disease, like if he's at risk, if he's a relevant or a relative of rheumatoid arthritis patient, if he's ACPA positive, is rheumatoid pocket factor positive, you can use the ultrasound and these findings to judge his case. But I would like to say a very important note here. The guy detected MTP affection or MTP erosion, that's one, and synovial hypertrophy by that is grade 3 by B mode. This is very significant. There are some reasons why we could not detect power Doppler. Maybe it's your settings. Maybe it's the machine settings. Maybe it's a compression. Maybe it's a deep site. Maybe the patient is on steroids. Maybe he had a local injection. Maybe and maybe and maybe. So the power Doppler is really good when positive, but when we have such agreement that he has erosion, synovial proliferation, by ultrasound, but we cannot see Doppler, we still can consider this synovitis and count it towards whatever you have in your mind, probably towards rheumatoid arthritis, psoriatic, or other diseases.
Thank you so much, Dr. Adham, for your excellent answer as usual.
For the probes, we usually use linear probes. Linear probe is the one that is used to examine most of the areas. It's similar to the one used by the examiners to check for the duplex, for example, and that's why we use the same probe to examine for vasculitis, for example. But I need to see the following, or to say the following. First, you have a recommendation to use the hockey stick when you have very small joints. So you can use hockey stick if you can. And in deeper areas, like sometimes the hip, but more importantly, the gluteal region, you can also use the convex probe. Now, if you can use either or, we prefer to use the linear, even in deeper areas, because it has higher resolution and you can adjust some software in enhancement of the image. But if you cannot, then you should use the convex probe, especially if the area is very deep, if the patient is obese, and so forth. Regarding the frequencies, we usually use more than 10 megahertz frequency to examine the musculoskeletal system, but you can go as high as 22 if it's very superficial and very small areas, maybe 14 to 18 for most of the areas. So again, 8 to 12 for the deep areas, 14 to 18 for most of the joint areas, 18 to 22 when you scan very superficial areas. I think more than 22, you cannot see even below the subcutaneous tissue. So maybe if you're studying diseases like scleroderma, systemic sclerosis, if you're studying the skin and directly subcutaneous tissue, you can use something above 20 that can show you some findings. And I have some mentors and colleagues who can use up to 50 and 70 probes, but they are not commercially available. They are special made and it's under evaluation.
Thank you, Dr. Adham. Another question saying thank you so much for this amazing lecture. In patients with square clinical picture, can ultrasound differentiate between inflammatory and mechanical presentation if the findings are synovial hypertrophy and effusion only with no power Doppler?
Yes, I mean, having only synovial effusion and no power Doppler, this is no more called synovitis. So we cannot really grade this as inflammatory disease or rheumatoid arthritis, for example, or inflammatory arthritis, because it can be done with trauma and other issues. But of course, having synovial proliferation by grayscale, with or without Doppler, is actually very peculiar depiction where it can take you away from just having a minor affection of one joint with effusion. If you have synovial proliferation with or without Doppler, this is called synovitis. So it will depend. Is it one joint? You can speak about monoarticular affection or monoarticular synovitis. Is it polyarticular? Is it symmetrical? And then you do what we call patient score. So, for example, what we said now, depicting synovial proliferation, is an elemental score. This, we're talking about one element, that is hypertrophy. We can detect a score by grayscale, by Doppler, or by combined scale. And then you score the joint with other findings, like what about erosions? What about the cartilage? If the cartilage is affected, if we have a power Doppler, if you have synovitis, then this is an inflammatory arthritis. Now, what about the patient level? Is it does it qualify for the minimum five joints per patient according to the 7 joint scores? So you can go to second and third MCP, second and third PIP, second and fifth MTP to check for rheumatoid. You can go for enthesitis score to detect if this patient has a qualifying enthesitis by scoring systems. So it will take you, if you find this synovial proliferation, to the elements of inflammatory arthritis. But again, if you only have synovial effusion, no hypertrophy by grayscale or Doppler, it will make your life difficult because this would widen the differential diagnosis into other things than or together with the inflammatory arthritis. Thank you.
Thank you, boss. Another question about what is the strategy we have to follow when there is a mismatch between clinical, laboratory, and ultrasound?
There are some papers who study those patients, because if you see, for example, Casper criteria for the psoriatic arthritis, or even some patients with rheumatoid, they sometimes present without inflammatory markers. Yes, it's higher in psoriatic than the rheumatoid, but it's found in almost most of the diseases, even the ones known to have a very high ESR-CRP. So let's agree first that not every patient, at least not 100% of the patients with inflammatory arthritis, would have high inflammatory markers. This is one. Second, you know that some inflammatory markers like ESR would be affected by other factors like pregnancy, like the use of steroids. So you can have false high or false low, and so forth. And CRP, of course, is affected by infections and other things. So whether it's high or low, you can use your ultrasound to confirm your diagnosis or your decision in case of clinical mismatch. I have mentioned that when we had patient in remission by clinical judgment, by patient judgment, by lab judgment, and ultrasound activity, we call this subclinical synovitis. And we have followed those patients, especially when you have a good rank in the score. It's not only one joint, it's a scoring system. This would correlate well and predict the flare-ups in inflammatory arthritis. And the same with remission. If you ask me if this patient is in remission, no, not necessarily. And this patient can still develop deformities. Like I said, in the era before where we didn't have a lot of medications and no ultrasound, we used to see these people with good ESR-CRP, good clinical remission, develop deformities still. Those patients qualify on the ultrasound for subclinical synovitis. In this case, you make a score. If it scores well, then you have to treat this patient according to your ultrasound activity.
Thank you, boss. I have two questions for you. Does the temperature of gel affect the results? You know, there is new ultrasound machines use a gel heater.
Yes, it's a very nice question. I hate those gel heaters because the gel quality is very important. Yes, it can make your exam difficult and it can affect the results. Why? Because at certain areas like the small joints of the hands and the feet, we should put a thick layer of the gel and we stand with a probe on the gel and don't touch the skin of the patient. Now, having the heaters can make the quality of the gel really bad and poor and so soluble that you cannot stand on the gel. It's not consistent. It dissolves into water. So this will hinder the coupling effect of the gel between the transducer and the skin. So you have to push more with the probe, and this can affect your image. I don't like them at all. And to know, when we were learning, they urged us to use even the gel pads that are contained. Why? Because we needed to have a thick layer between the gel and the skin and not to compress on the skin. So the heaters, if they make your gel material so soluble and like watery, it will really hinder the coupling effect between the skin. Because one major function of the gel is a coupling material that propagates or makes the movement of the ultrasound waves easier. The second thing is the introduction of air. Our gel is mainly put on the patient and not on the probe. For this reason, we should not allow air inside, because the air will hinder the image and will not allow the ultrasound waves to penetrate through. Again, gel heaters would make the quality of the gel less and probably allow for compression and air to be between the transducer and the skin.
Thank you so much. The second question, what is the technique for injection of the small joints do you prefer? out of plane or in plane? And is there a risk of puncture of the tendon or tendon rupture?
It's a very nice question, Dr. Abdallah, and I know you're very experienced with that. So it's a mainly question to probably explain to the attendees techniques. For me, in the small joints, I actually prefer the out of plane technique or coaxial technique. Believe me, at this stage, when you are experienced, it's much easier than what our doctors prefer in the beginning, to have an in-plane technique. Because with the in-plane, you cannot change the angle much. For example, if you're under the plane, under the probe, going to the MCP joint here, here's your needle, and you cannot really direct it like this. So it's better to use the coaxial technique to inject. Now, there is a possibility that you can affect or let's say injure some structures, but I am rather keen about the articular cartilage when you puncture it with the needle, probably more than the tendons, because the needles that we use to inject the small joints of the hand are really tiny. So even if you go through the tendon, probably you're not going to cause much damage. But again, if you want to avoid this, you can easily do it by moving your proparamedian, for example, or choosing which direction you can go in and coaxially choose not to go through the tendon. Although personally, I don't think this is the major issue, but there are some difficulties in some other structures to avoid. But thank you for this question, because it's so clarifying for the people.
Thank you so much. Is there any questions?
Okay, I think that's all.
Thank you, Professor Dr. Adham AboulFotouh, for your excellent, up-to-date, to the point presentation and comprehensive answers to all questions, either related to the today issue or outside the topic. Some people come and attend to listen to Dr. Adham, and they have a lot of questions to him, so they have the chance to ask about anything.
Thank you very much, Dr. Abdallah. I really appreciate your presence. Dr. Abdallah, by the way, is in Singapore, and he has a different time than us. He's after a long travel. So I really appreciate him taking his time to be with us today and enrich us with the nice, really informative questions. Any other remaining questions, or probably no, nothing? I cannot see anything in the chat and the question and answers. Thank you so much. I would like to thank Y-Sonic ultrasound machines that are coming soon to Egypt and well known in the different parts of the world, for holding this scientific platform for us to illustrate some good relevant information to our doctors. And thank you, Hisham, specifically for taking your time and effort and following up with us all the time. So thank you so much.
My pleasure.
Thank you again, Dr. Abdallah, my dear friend, colleague, and brother, and all the best for your international tasks, and looking forward for more cooperation in the coming future. Thank you so much.
Professor
Okay. Thank you, Dr. Adham, for your wonderful
and thank you, Dr. Hisham, to give me this chance to introduce my teacher. He is my teacher before becoming my friend and my brother.
Thank you. Thank you so much.
Okay, thank you, Dr. Adham, for your presentation, and thank you, Dr. Abdullah, for your helpful assistance. I think that's all, and time to say goodbye. To follow up with more information about Ultrasonic webinar, you can follow us on Facebook and LinkedIn and our YouTube. Again, thank you, Dr. Adham. Thank you, Dr. Abdullah. It was my pleasure to join this webinar with you. And I think that's all. Bye-bye to everyone.
Bye.
Bye.
Bye, Professor.